I'm Dr. Brett Levine, and I'm the Director of Adult Reconstruction here at MedStar Georgetown University Hospital. The type of patients I see, again, are all comers. So I like to see people obviously with hip and knee because that's my specialty. And whether it's an initial evaluation just for early arthritis, requires injections and stuff like that, and building a relationship before having surgery to people who come in with implants that are loose or infected, for a revision. So happy to take care of all those patients from the simple primaries to the more complex revisions. And doesn't matter anatomy, shape, size, whatever it might be, take all comers and try to figure out the best solution for each person. In high school, I worked with my dad on cars. And so ironically, a lot of the instrumentation that we use in medicine is not that different from working on a car. I got really good at taking apart cars and transmissions and putting them back together exactly how they came out. And then I came to undergrad here in Washington, D.C., worked at the hospital here, and then saw a total joint replacement by Dr. Brian Evans. And that was it. I was hooked. I saw what he was doing, the instrumentation he was using, the way the surgeries went, and I said, that's what I have to do. And then seeing the patients in clinic and how they do and how they're so grateful, that was just icing on the cake. My specialty is adult reconstruction, which encompasses hip and knee reconstruction, mostly basically replacements, some trauma work around that area as well. But it's from as little as partial replacements of the knee all the way to replacing a full femur bone as necessary. I do take my time in clinic, and when I see them, they will see me rounding on them in the hospital much earlier than they want to see me. I take time with each person, so when I'm there, it's individualized care. Everybody gets what's best for them, which will be different than the next person that walks in. So, I just ask for a little bit of patience because each person will get their time. I'm not going to cut anybody short. I like working with patients. I love teaching residents, fellow students, whoever I think will listen to me, because I love joint replacement, all aspects of it, from the littlest of partial replacements to the most complex revisions. It's a great field in that everybody's different. Even though it's the same surgery, a knee replacement, but everyone's anatomy is different, so a knee replacement is not a knee replacement for everyone. You have to do different things in each case. So every day's new, every day's exciting. It's a great specialty. That's what gets me up every day to come to work. So my philosophy of care is to individualize treatment for each patient. I think, again, everybody is not the same. It's the same name of the surgery, total knee replacement, total hip replacement, but for each person it's going to be different. People may have sensitivities to pain medication or intolerance to certain aspects of the surgery, anesthesia, whatever it might be. So I like to sit down and come up with an individualized plan for each person. We plan out the surgery beforehand, go through all the steps of the surgery with patients, which is why I do ask for them, again, to have some patience in the office with me, because we will cover that for each individual person. And then hopefully at the end of the day, they will look back and say, this was like for me, not for anybody else. And then I feel like that's, in moving away from where I am now, that's the thing that patients have come back to say to me is the most important thing, is that they felt like that when they were with me, they were my only patient. So that's how I try to treat everybody. There's a lot of pluses and minuses to the new technology involved with knee replacement. I am in the middle of my career. I'm not at the end, but I feel like I may be a little bit of a dinosaur in some of these things because I like to adopt things slowly. In my personal life, I love technology and gadgets, and jump on board right away. But when it comes to a person's life and putting implants in, I'm a little slow to adoption to make sure that research is there. So the most common question is, do you use robotics or some sort of technology to do your surgeries? And at the moment, I'm evaluating it, but I haven't jumped on board with it because, again, technology, it may be good at sometimes, but sometimes it may not be the best thing. The joke in our office is that when you get on an airplane, you don't knock on the cockpit door and give the pilot a flight plan. You trust them that they're going to get you where you need to go. And so for my patients, I promise them that, don't worry, I got the flight plan. We're going to get you there safely, and it's going to come out the way we want it to. There's a few different ways to get into the hip, I try to break it down to patients that you can come from the front, you can come from the side, you can come from the back. I've tried all of them, and the most humbling aspect of it all is it had nothing to do with how I did the surgery. It was all about the patient. It was about their preoperative education, how ready they were for the surgery, You know, it was kind of eye-opening when we did a study 15 or 16 years ago where we were sure that one was going to be better than the other. And as it's panned out, there really doesn't seem to be much of a difference. When people come in and we have a discussion about when it's the right time for surgery, which is different for each individual person, sometimes it's injections for 2, 3, 5, 6 years, and then they're finally ready mentally to have the surgery. So the most important thing is that we confirm radiographically that they're a candidate for surgery. Then ultimately it comes down to them deciding based upon their social calendar, their family calendar, just life in general, when is going to be a good time to have surgery. In general, there's never a great time for surgery. People aren't necessarily like, gee, I want to have surgery at this time. So you try to pick what works best for that individual person. And then once they come in and you have that relationship and they decide to have surgery, then you move forward with all the preoperative testing and the discussion. And all along the way, it's kind of confirmed, this is what you want to do. This is going to be the outcome. And so everyone's kind of on the same page. And as far as here at MedStar, they have all the options covered for hip replacement, knee replacement, whether it's robotic assisted or it's some sort of technology assisted hip or knee replacement is available. The multiple approaches to the hip are available. So you really got it all here. So again, this is probably the best place to come to get whatever type of care you want that's going to be individualized for you. The average age of patients that I see for hip and knee replacement usually falls somewhere in the early 60s. But that being said, sometimes it gets to the point where the cartilage is gone and there are no other options and you have to do the surgery. So I've operated on as young as 16 and as old as 98. And to be honest with you, it may sound a little crazy, but that 98-year-old patient was hands down one of the fastest recovering patients I've ever had because they went into the surgery. I don't have a whole lot of time left. I got to get through this recovery and get back to my golf because this is what I love to do. And 6 weeks later, was at swinging the golf club again. So it's not only the age; that's just one part of it. And if there's nothing left to do, if your joint is completely degenerative, then joint replacements are very good. They will last 15 to 20 plus years, and we have great solutions afterwards. So for the 16-year-old, she's now actually in her 30s. And she's still on her first hip replacement, but probably will need a second one sometime in the next 6 or 8 years. That one will go in and probably last her a little bit longer because she's not as active. And then she may only need one more surgery after that. And with the current replacements, for the most part, we can change just the plastic or the polyethylene part of the replacement. So the next revision doesn't have to be the whole thing redone again. And I've changed some of my former partners' patients' polyethylenes once or twice over the course of 20 years. And so someone who had surgery at 20, then had the plastic replaced at 40, had it replaced at 60 again, and that's it. And so the plastic change is a relatively easy surgery, relatively easy recovery. And so for those people, holding it back at 20 would have been a mistake because they would have run into the problems of recumbency. So they would have probably gained some weight. Medical health wouldn't have been as good by the time they hit 40. And they wouldn't have enjoyed their 20 to 40 years of life and waited till they got to 60. They would have to wait 40 years before they were of age to have the replacement. And what would they have done during that 40 years? It would have been pretty miserable. So the age it's one factor, and we don't love operating on super young, but when there's no other options, it is a great option then. Sometimes the answer is yes. When they come in and they're not ready, I try to explain it to them a little bit like when you go shopping, you want to get a really good deal. And so if the only thing you can't do is something that I don't want you to do after the surgery, then you're not going to get anything back after the surgery that you're happy about, so you got a bad deal. So for instance, like when people want to run, I don't really suggest that you do a lot of running. So I suggest you get that out of your system, then you come back and you have your replacement when you're ready. Versus people who don't want to walk down the stairs, can't put on their shoes and socks, that kind of stuff. That's when it's more of a discussion like, all right, you're going to get a huge benefit after the surgery. And so you shouldn't be afraid because this is what it's going to do for you. Yes, things don't always go perfectly and there are complications, unfortunately, but those are relatively rare. And you balance that with the person. You try to optimize them before the surgery, make sure that they're ready. And then if you do that, usually it's a pretty good success rate. And if they're on board with their expectations or what I can give them, then we have really happy patients. When people are expecting a knee or a hip that makes them 20 years old again, that's not going to happen because the rest of them is not 20 years old, and that's where sometimes expectations are off. So you try to align that, and if you do, the outcomes are usually pretty good. There's a variety of reasons why joints wear out. It could stem from genetics. There are people in their family, it runs in their family, that they're going to develop osteoarthritis. There are people that have other disorders like rheumatoid arthritis or malformations of their bones, so that it puts abnormal stresses on their bones, leading to arthritis. Sometimes it's wear and tear. Sometimes it's the weekend warrior that has a little bit of degenerative changes, and then they're running and pounding on their joint. And then it progresses more rapidly. For whatever reason, though, whether or not arthroscopy and other things have accelerated the need for replacement, with younger athletes getting surgeries where you're removing some of the cartilage earlier in life, translating into needing a knee replacement or a hip replacement in the future, that may be part of it. But in the end, a lot of it is wear and tear, and the fact that because the surgery is so successful, because it does last so long compared to what we used to think, people are willing to do it earlier in life and regain that quality of life at a time where they feel like the golden years may be a little earlier than we thought. A lot of my patients will tell me, at 70, they're like, oh, the golden years were probably 50s and 60s. I waited to 70. I should have done all this stuff when I was 50 and 60. So we're having that sort of intolerance of not being able to do that stuff in the 50s and 60s. So younger patients are becoming candidates for the surgery. The most important thing when you decide to have a joint replacement is that radiographically, you do have bone-on-bone arthritis. There's been a lot of research that's looked at, and it sounds intuitive. Like if it's not bad arthritis, how are you going to do well? But there have been research studies that show the less arthritis you have, actually the worse you do. So you want to be maybe not at rock bottom, but you want to be heading towards rock bottom, and then the surgery won't seem so bad, and you'll bounce back very quickly. If, again, like I mentioned before, for when you're a candidate for surgery, if the only thing you can't do is run, then we don't want you to run after the surgery. That's really not a good time to have the replacement. You should run until you wear your joint out, then have the replacement when you're ready to do activities more like the pickleball, which is the rage now, doubles tennis, golf, things like that. When you're ready to dial it back, those are the type of activities that joint replacements do very well for, and are probably going to last 20 plus years for patients. For joint replacements, there's two different options here. You have the knee side and the hip side, and so they both do well in the end, but the paths to get there are quite different. So for the average recovery for a hip replacement, it's pretty quick. The pain relief is really, really fast. Within a few days, people feel no worse than they did when they started, and within a couple of weeks, they already feel better. So I'm usually slowing people down. Because the reality is we use cementless implants, meaning the bone grows into the actual implants, into the metal, and once that happens, it's fixed with them pretty much for life. So in the first 6 weeks, that's when that happens. So I usually tell people, don't get too crazy in the first 6 weeks. It's just unnecessary. You don't need to start training for your marathon. You don't need to ride, 100 miles. You don't need to walk that round of golf in the first 6 weeks. Take it easy, let the bone stick to your implants, and then you're good for 20 years. After 6 weeks, you can start to have at it. And most of our patients will return to sports between 6 to 12 weeks. For the people who are just looking for walking or driving, that could be pretty quick. That could be 2 or 3 weeks. They're back to getting in a car and driving, walking around a mile or two. We just encourage them to not do the excessive stuff very early. The knee side's a little bit of a different story. The knee side, you really want to block out a good 4 to 6 weeks to focus on yourself, where you can really work on your range of motion. Some people get the range of motion in a couple of weeks, and then the rest of the recovery is not so bad. Some people, it takes them 4 to 6 weeks to get their range of motion, and that's the key thing. If you want to have a great outcome for knee replacement, you want to have that range of motion be as complete as possible. So you got to get that. For some people, it takes about 6 weeks. Because if you can get your knee somewhere between 110 and 120 degrees of bending, there's nothing that you won't be able to do afterwards. Coming up and down stairs becomes easy. Getting up and down off the ground becomes easy. So then, that gives you the opportunity to play with your grandkids, your kids, whatever it might be, and really have almost no restrictions on what you can do. But that takes a lot of focus, and in the first 4 to 6 weeks, versus a hip replacement, it just comes, you just walk and it just gets there. Again, for both of them though, about 6 to 12 weeks is my recommendation for when they want to start playing any type of sporting activity. My father-in-law has had his joints replaced, and I made him wait to, I didn't do it, but made him wait to 6 weeks, and sure enough, at 6 weeks, he's back out having his first round of golf. So can definitely be done if you put your mind to it. There's no doubt that at 6 weeks, you can be ready to return to that type of activity. The role of physical therapy and rehabilitation and recovery after a joint replacement really depends upon the individual patient. So some patients are super disciplined and don't need that much because they're capable of doing it themselves. Most are not, and do require going to a more regimented physical therapy program. And so they could be absolutely crucial to the recovery for the people who, not that they're lazy, but they're not going to get out and do the activities without someone making them do it. And so in those cases, therapy is absolutely crucial for them so that they can get that range of motion, get back to the activities. And for some people, it's kind of like a safety blanket. They just like to have someone there that's telling them what they're doing is okay and that they're advancing at a pace that seems good, since you see your physician in the office before surgery, you see him maybe in the hospital, and then a few times in follow-up. The therapist you might be seeing every day or 3 or 4 times a week for weeks, they become a little bit closer to the person, and so that sometimes that becomes their safety blanket on when they can progress. And some people do need that. It's not absolutely vital for every single patient, but in a lot of cases, I would say well over 80%, it is a vital part of their recovery. Yeah, for return to sport after joint replacement, I usually suggest that they wait between 6 to 12 weeks after the surgery. And there's a list. I was part of a survey, I think it was in like 04, 05, and then they redid it maybe about 10 years ago, what is approved and what's not approved for patients to do. And most surgeons would suggest that high impact activities are probably not a great idea for joint replacement patients. If you're going to do them, you want to do it in moderation. But other activities, pickleball, golf, doubles tennis, skiing if you know how to ski, ice skating if you know how to ice skate, those kind of things are all approved and certainly patients can do and can get back to if they put their mind to it. After a joint replacement, it is definitely possible to go home the same day. It does take a lot more planning on the surgeon's part, on their staff's part, and on the patient and their family. So everyone has to be on board with this together. If they're not, then it doesn't work out very well, and people start coming back to the emergency room early because they're not sure about things that are relatively simple after the surgery that they just weren't expecting. So if you take the time and you have a good conversation with the person, there's good materials for them to read, and they get all their questions answered. There's also an open line of communication after the surgery, so that if they have some quick questions or whatever, they can get them answered. There's also opportunities. There's chat bots out there that we've utilized in the past where we'll send them text messages to preempt questions that are coming. In that, if you have all of that working for you, it is possible to go home the same day. Again, it's select patients, medically healthy patients. I think one of the issues we do run into is that people don't have to go home the same day. There are a select group of people that want to go home the same day, and if that matches up, then you get those people home the same day, and the people that need a day or two in the hospital spend the time in the hospital so they get what they need as well. Preparing for surgery is super important. We try to give patients exercises to do before the surgery. Now, if they could do physical therapy to the fullest, they wouldn't be having surgery. So we try to give them some simple exercises. They look sometimes ridiculous, the exercises, and people will blow them off like this is not going to help me. But the exercises are actually really good. It's for the upper body. It's for a lot of the other muscle groups that you're going to need for the recovery. So if you get yourself in shape and ready to go as far as doing the exercises, you read through the exercises you're going to need to do for whether it's a hip or a knee replacement, so you know what you need to do after the surgery. It's way better to do that when you haven't taken any pain medicine, you haven't had any anesthesia. If you have that cold, it makes it easier for your recovery afterwards. You want to talk to your medical doctor, make sure you're optimized for your medical health. This is elective surgery, so if you're having chest pain, if you're having other issues, you deal with those things first and make sure you're in the best shape possible for the surgery. And then the last thing is nutritionally, we try to get people to eat a nice healthy diet before the surgery, lots of protein so you have all the building blocks to recover. And if people do that, they can really get themselves ready for the surgery. And it's amazing after the surgery when people come in and say, oh my God, that preparation made this so easy. Now, I'm not 100% sure the preparation always did it, or it was the expectations and the conversations that we had, but it's such a good feeling to hear them say that that was so worth it for the people that take advantage of it preoperatively. In seeing all patients, we definitely deal with various subspecialty of patients. And there is actually, believe it or not, a Facebook page, which apparently my name is all over, for patients who are morbidly obese. And so when patients come in, we have that discussion as far as what their body mass index is. And I don't have any strict cutoffs because it's not just the weight alone that's the problem. It's the weight distribution, where it's being carried, other medical problems, including malnutrition, diabetes. If all that stuff's under control and the only thing is the weight, then we have that discussion of, all right, let's see if we can get you to a better weight category that makes you lower risk for surgery. Or for some people, their joints are so bad, they can't make it to that weight, and you have that conversation, risks and benefits, and ultimately you wind up doing the surgery when the person feels like this is gonna be the best I'm gonna be for the surgery. I'm not a huge fan, and it may not be great for some of the other departments like general surgery. The bariatric surgery patients, there's a lot of research back and forth. We're not sure that bariatric surgery is actually going to lower your risk after the replacement. So it's better if you can see a nutritionist, take advantage of all the other resources at the hospital here, and you try to lose the weight naturally. So you get an exercise regimen down, you get a nutrition regimen down, and if you can do it easily, where you're losing 3 to 5 pounds a month, if you do that for 3 or 4 months, 5 or 6 months, all of a sudden, believe it or not, you drop down a category of risk, and now you're more ready to have the surgery. And that's also more sustainable. You can live the rest of your life once you have a diet and a regimen that's easy to follow, rather than trying to do these quick fad diets. To speed up your recovery after the surgery, the most important things probably are, again, what we discussed before, which is pre-op. So if you're ready preoperatively, mentally, physically, and your medical health, the recovery afterwards tends to be a lot better and a lot faster. And then after the surgery, it's important to listen to what your physician says. So each physician may have a slightly different regimen in what they suggest because that's what works for them. So you want to follow that, whether it's the use of medications, the avoidance of some medications, certain exercises to do. If you follow the plan, usually it will work out better. Most of the docs that I know, and the docs here, they have their own plans for years and they have good success, very good success. So you probably want to make sure that you stick to what they're telling you to do, and if you do, you'll follow that path. If you veer off that path, you can veer off in the good way, you can veer off in the bad way. So best to kind of listen to what your physician says, work hard, and I try to tell our patients that this is your Super Bowl. Before you're training for this game, this is your game. Come in excited, come in ready, and whatever's thrown at you afterwards, you're going to tackle. And then 6 weeks later, you're going to come out, and if you're a golfer, you're playing golf. If you're a pickleball player, you're playing pickleball. If you just like to walk, you're walking pain-free. So just keep that in mind, and if you do, a lot of times you'll sail right through the recovery. The future of joint replacement surgery is very optimistic. We continue to improve the quality of the implants that we're putting in. We're improving the instruments we use to put them in, so we can be more precise. I really think that the buzzword of artificial intelligence is going to keep creeping into medicine, where we'll be able to eventually have enough data to know that a patient of a certain height and a certain weight and a gender, this is probably the best replacement for them. this is probably the best replacement program for them, or even to the point where we have some smart implants that we could track the number of steps so patient expectations can be reasonable. You can expect to do this number of steps at this time. Your gait speed should be resuming normal at this time. Stair climbing and descending should get better at this time. A lot of this is based upon data that we have, and as we have more data, I really think that we're going to be able to plug that in for like a great individualized program. Be able to look at the person having a hip replacement, you look at their knees, their foot and ankle, their medical health, their height, their weight, and overall genetics, and a program will be spit out, like this is the best implant, this is the best recovery for that person. And I think that's probably coming over the next 10 years as we keep collecting data. I guess one of the best things of being mandated to collect patient-reported outcomes is that we now have this data, and as we start plugging in the patient characteristics, we can really hone in on what's the best thing to do for each person. One of the things that I tell patients all the time is that there is no dumb question. So when you're in for a consultation, or you're at home and you're thinking before surgery, gee, I wonder if I should ask this question. The answer is always yes. Part of our job is to answer those questions to make the person feel comfortable and safe for the surgery, or whether it's an injection. Make sure you're happy and understand that when you get an injection, you might not be able to have surgery for 3 to 6 months, depending upon the surgeon and the type of injection. So based upon those type of things, it's important to ask whatever questions you have. And no question is silly, because you'll probably say to somebody else after you've had your joint replacement, they'll ask you this question, and they're going to think it's silly, and you'll be like, oh my God, I had that same question. Which is why we do have this chatbot program that I've used for the last six years or so, and they're like, you're reading my mind. And it's because most joint replacements patients have the same questions at the same time. Sometimes they're just afraid to ask those questions. And way better to ask them than keep it inside and then find out later, you could have been doing this better or that better or more optimized for the surgery. A lot of people don't ask, how do I get ready for the surgery? They just kind of come in and they're like, and then they leave and they're like, gee, I should have asked, how do I get ready for the surgery? And while we may give you a handout that says this is how you should get ready for the surgery, it's still not as good as having that conversation. One of the most embarrassing or awkward questions that patients tend to have is when they can return to sexual activity after surgery. We actually do have a handout from a couple of papers that have been written in the past, which are safe positions, when it is safe to return. It is a question that I'm completely comfortable having that discussion with, but it always tends to be like as they're walking out the door, under their breath, and we're human, so everyone has certain desires, and if you feel like that's something you're planning on doing, it's better to have that discussion so you can do it safely, and do it at the right time so that you don't hurt yourself. Yeah, don't be embarrassed for that question. That's just one of the questions. There's a lot of other things that are along those lines, or different areas of life. Feel free to ask those questions whenever you have them. So I think a better question is, why shouldn't they choose Georgetown as for their care? It's a great facility, brand new operating room. It's got great facilities on the floor, the nursing staff. I can't say enough about all the people that work here. You're going to get great individualized care. It's in a great location. It's got a great view of downtown from the new tower there. So really, I can't think of any reason why you wouldn't want to. You're going to get comprehensive care for joint replacements. That includes plastic surgery when necessary, infectious disease when necessary, the medical team when necessary. So not all joint replacements are simple and easy. Sometimes we need the help of others, and we have all that right here as one big package. So I would pose the question more, why not come here? Because I think this is the best place to receive your care.